my work for the last several years, and it is indeed an honor that you could be here in the dying hours of this meeting. So with that, I'm going to present an outline of my talk today. We will discuss some of the unique aspects of epidemiology of chronic kidney disease in children, discuss factors affecting progression of CKD in children, and also discuss unique determinants of outcomes in children with CKD. To set the stage, let's talk about a case very briefly. It's a 13-year-old Hutterite girl. For those of you who are not familiar, we have Hutterites living in the province of Alberta. They're descendants from a German population that came several years ago, and they stick to communal living, and they do not integrate very well into the mainstream society, and there's a lot of consanguinity. So this child had prolonged bedwetting, developmental delay and dysmorphisms, a short stature, about his knees, fatigue, and color. When we examine her, her height and weight are at the 3rd percentile, and blood pressure is greater than the 95th percentile, and of course she's pale, and her hemoglobin is 59, creatinine almost 1,000, with very high urea, high phosphate, and normal potassium. On imaging investigation, she has a small single dysplastic kidney. Some of the pediatricians in the audience may have thought she had nephronophthisis, which is a good differential, but she just simply had a small dysplastic kidney, which outgrew with her. So begins the life of a child with chronic kidney disease, or ESRD, a child who should be full of vigor and youthful, now confined to being dialyzed 3 times a week by hemodialysis or by peritoneal dialysis at nighttime, as was the case for our child that I presented. Everyone in this room is quite familiar with the challenges of end-stage renal disease, managing that in adults. However, as a pediatric nephrologist and looking after children with kidney failure, some of the things in red highlighted here are a big deal. So frequent hospitalization, missed school vacations, malnutrition, diet restriction, poor growth, short stature, and severe cognitive deficits that they accumulate over time. So this is really a segue into discussing unique aspects of epidemiology of CKD in children, which is really my work, and then we'll talk about the factors affecting CKD progression, which I'll summarize the collective knowledge from various investigators here in the US and in Europe, and we will go from there. So if you look at the Canadian Organ Replacement Register and look at who has who has kidney failure as a child in Canada and what are the causes of kidney failure, we find that about 1/3 of the children have congenital anomalies of the urinary tract, which is not surprising to all of us. 1/3 will have glomerular disease, and then diminishing numbers of genetic disorders and other disorders like HUS. But if you stratify the causes of ESRD by ethnic origin, we find that there's a disproportionate representation of, for example, the Aboriginal or the Indigenous peoples of Canada. Caucasians make up about 61% of the registry, while the Aboriginal patient make up 12%, but really only 6% of Canadian children are Aboriginal. So we looked into this further to understand what it is about the Canadian Aboriginal people that puts them at high risk for kidney disease, even among children. And the First Nations, Métis, and Inuit are 3 people groups that make up the Canadian Aboriginal population. So we found that in every single age category from 0 to 5 to 18 to 22, Aboriginal males and females have 2 to 4 times higher risk of chronic kidney disease, in particular end-stage renal disease, compared to white children. And when we looked at why, we found that glomerulonephritis seems to be the driving force behind the high incidence of ESRD among Aboriginal people Aboriginal children in Canada. This is against our common knowledge that congenital anomalies of the kidney and urinary tract are the most common cause of kidney failure in children. So that is just to set the stage as people who have gathered here from many different nations, that for you to pay particular attention to your demographic and to the epidemiology of disease within your communities, and to the answer of what is the most common cause of CKD in children. Really the answer is D, frequency varies with ethnicity and gender. Changing gears to understanding CKD in children, we talked a lot about GFR with aging. Critical thing to know in pediatrics is that a normal GFR for children varies with age. It is about 40 mils per minute for a newborn and approximates adult GFR at 2 years of age. So the CKD classification developed by Kadigo, our chairman here, led the work group, and so when we look at this GFR classification, it's not immediately applicable to those under 2 years of age. But using the information we have and looking at CKD stage 5 or G5, there's a lot of information around the world about the incidence of ESRD, or end-stage renal disease, in children. This slide comes from the USRDS annual data report for 2012. We had the pleasure of submitting Canadian data, which is the CORR, or Canadian Organ Replacement Register, to put it as an international comparison in the annual data report last year. And we found that incident rates are 50% greater in American adolescents compared to Canadian adolescents. They are very similar countries, but with different insurance systems and different ethnic demographics, and therefore we find that there are differences in the incidence of ESRD. The top brown line represents the year-to-year incidence from 1990 to 2010 in adolescents, and the lower lines represent younger children with a lower incidence of ESRD. So what about earlier stages of CKD, the stages before reaching end stage? Well, the prevalence of CKD in children is really largely unknown, and there are a lot of genetic, ethnic, and country differences, as I've already alluded to. And these estimates are also affected by accessibility to medical care, local referring and reporting practices. The best data for pediatric CKD come from surveillance study that was done by the Italians in the 1990s, where they recruited patients who had eGFR of less than 75 and were able to calculate an incidence and prevalence. So the mean incidence of CKD, eGFR less than 75 mils per minute, was 12 cases per year per million age-related population, and a prevalence of almost 75 cases per million. And similar data are now being published from the UK. A recent study published from a children's hospital in London showing that the mean incidence and prevalence of children less than 16 years of age with CKD stage 3 to 5 was 75 and 90 per million age-related population. These are some of the very interesting information that are coming from different countries to inform us about the prevalence of CKD in the pediatric population. I put up this slide to show you that there are large areas in the world where we do not know the prevalence or incidence of chronic kidney disease among children, and for that matter, adults. And why should we care? We know for pediatrics there are sparse reports coming from the developing world. For example, in Nigeria, a recent publication from the Ocean State shows an incidence of 11 per million age-related population incidence of ESRD and a prevalence of 48. And a soon-to-be coming out publication from the Oyo State also describing incidence and prevalence of ESRD in Nigerian children. And it's very important to tell the story of pediatric ESRD. The pediatric data is important for advocacy and awareness, for developing strategies to reduce burden of disease and to evaluate effectiveness of interventions and to improve quality of life in these affected children. And I propose this philosophical challenge to you. If a tree falls in a forest and no one is around to hear it, does it make a sound? If there's lack of data, the story is as if a tree falling and no one hears the sound. But mortality rates in children with ESRD is remarkably high, 30 to 150 times higher than in the general pediatric populations. But we know that outcomes are improving with time. This recent publication in the Journal of the American Medical Association by a colleague of mine shows that there are significant improvements in 5-year increments in calendar year over the last 20 years. So we are improving dialysis mortality for children in the United States. But there are opportunities for improvement, for early detection and management of CKD to delay and prevent progression to ESRD and to improve overall survival. So with that, I'll move on to discussing the factors affecting progression of CKD in children. When I thought about how to present this talk, there are multiple factors that are putative affecting progression of CKD, and we can divide them in various ways. But for the purposes of a pediatrician, I listed the things that are most important to us. So modifiable and non-modifiable factors. Just as in adults, hypertension and proteinuria remain the most important modifiable risk factors, followed by bladder drainage and urine infections, health system factors, and various non-modifiable things such as etiology, GFR at birth, what you're born with, growth, and puberty, and I'll address this in more detail. It's important to realize that the evidence for risk of progression of CKD in children is less robust when compared to adult evidence, and it's based on largely retrospective or prospective observational studies with a smattering of RCTs. The most significant advance in our understanding of chronic kidney disease in children comes from a cohort study led by Dr. Firth and others in the United States called the Chronic Kidney Disease in Children, or CKID study, and this shows tremendous promise for the future. The earliest evidence about CKD progression in children come from a European study looking at nutrition in ESRD. Their hypothesis was that low protein intake would improve or slow progression of CKD. But in fact, they found that both proteinuria and hypertension were associated with progression of CKD, and in fact, the protein diet did not matter. This was a randomized controlled trial with a 2-year follow-up period of almost 200 children in Europe. So what about hypertension in children with CKD? It's common, it's undertreated, and a cross-sectional analysis of the CKD